pre-record. He started a state-of-the-art lecture for us. It's my pleasure to introduce the slides for Tony Lembo, Professor of Medicine at Harvard, Director of the IBS and GI Motility Centers there, an old friend and someone who's played really a critical role in the development of multiple drugs for IBS over the past decade. So if we could cue up Tony's slides, and Tony, welcome. Volume.
In Boston, Massachusetts. I want to thank the organizers, Gareth, Eric, and Vinay, for this kind invitation. I just wish I could be there in person to enjoy Dana Point with you. But again, thank you for this invitation. The next 35 minutes, I'm going to be talking about modern management strategies for IBS. And I hope to really just highlight some of the new areas of treatment as well as research into the pathophysiology of IBS. This shows my disclosures. The objectives are really to focus in on how we manage patients with regard to the doctor-patient relationship. We'll focus on lifestyle management, particularly diet, which I want to show you some new data, both on treatment and pathophysiology. And I'll give some highlights of the pharmacological therapies and just very briefly talk a little bit about psychological therapies. So as we think about IBS, it's good to remember who we are seeing in the office. And to do that, we need to know who are the people that seek medical care. We know that the vast majority of people that have IBS symptoms are non-consulters. Data suggests that about 75% never seek consultation for their IBS symptoms. About 25% seek care. The vast majority are seen in the primary care setting, with a subset in the GI or other specialty clinics. The real question is, who are the people that go from non-consulters to consulters, and why? The data suggests that the more severe that the pain, abdominal pain is, the more likely they are to seek care in a primary as well as a specialty clinic. And the other factor is psychological disturbance. The more the patients experience anxiety, depression, and other psychological disturbances, the more likely they are to seek care. It's important to remember that the psychological disturbances is not the reason for IBS in the majority of people. It may trigger or exacerbate symptoms, but not actually the cause, because the presence of psychological disturbance between a non-consulter and the general population is actually very similar. The other thing to think about in your patients is whether or not there is coexisting other pain conditions. And some of them are listed here, both pain and non-pain conditions that are important to think about in the prevalence that is seen in IBS. The reason for this is that when these comorbidities exist, patients have a greater impairment of the quality of life. They tend to have more severe IBS symptoms, more anxiety and depression, and more illness-related work absenteeisms. So when these other comorbidities are present, really you should consider about a multi-specialty approach for treating these patients, and referring to other specialties. Also consider centrally acting agents, which we'll discuss in a few minutes, and a very important psychological consultation when appropriate. This was an interesting article that many of you may not be familiar with, but I want to just take a minute to review because I found it very helpful in my practice. And this was an article that looked in great detail with scientific rigor, ways to foster physician presence in connection with patients, and really not only to improve outcome with patients, but also to improve physician satisfaction with it. And a few of these points have been really important. I've tended to use in my clinic, and I'll just read them here. And some of them are pretty obvious, but I think it's important for us to just take a minute to think about them. Prepare with intention. Take a moment to prepare and focus before greeting a patient. And they give a great example, which I now use in my clinic. That is to take a deep breath before entering the patient's room, so you can focus your mind, focus your mind on the patient. Listen intently and completely. Sit down, lean forward, avoid interruptions. I know we all know this, but it's important to remember to do this. Agree on what matters most with the patient. Find out what the patient cares about and incorporate these priorities into the visit agenda. Connect with the patient's story. This is how we can foster a stronger relationship and gain more satisfaction for us as well. Consider their life circumstances that influence the patient's health, acknowledge positive efforts, celebrate successes. So in other words, don't always criticize the patient that they weren't able to lose weight or do the things you recommended, but even small steps you should celebrate with them. And explore emotional cues. Notice, name, and validate the patient's emotions. A few years ago, we did this study that emphasizes this patient-centered approach and how it can improve IBS symptoms. In this study, we randomized IBS patients into 3 groups, either a waitlist group that did not have a lot of interactions with the clinician, a limited doctor-clinician interaction, or an augmented one. And the augmented one interaction had a warm, empathetic, and confident relationship, active listening, and my favorite, thoughtful silence. Let me think about your symptoms. A minimal physical contact, and increased time, but only about 30 minutes over 3 weeks, and shown are both global improvement on the left and adequate relief. And as you can see, there was a greater clinical outcome, at least for this 6-week study in IBS symptoms. Again, suggesting not only can we improve the relationship with patients, not only does that improve their outcome, but again, also improves physician satisfaction. Now, when we think about lifestyle management for patients, there are 4 general recommendations: increase exercise, sleep well, eat well, reduce stress. Now, these are helpful for everyone as listed below, but also particularly helpful for IBS patients when we know that they have a strong brain-gut interaction, and these can all affect. I do not want to focus now on food, because this food is a key trigger of IBS. We know that the vast majority of people report food to trigger their symptoms. The real question is, what is the mechanism or mechanisms? We know that allergies to foods are very rare, tend to occur in children, and much less so in adults. It's probably not the main trigger in the vast majority of IBS patients. Yet most people probably have an intolerance or sensitivity, and these terms can be used interchangeably, which are probably the majority of people will have this as a cause. So what are the causes of this? Well, there is malabsorption, which can occur particularly as FODMAPs, which we'll discuss in much more detail in the upcoming slides. Foods also have pharmacological factors. Just think about caffeine and the effect it can have on the body as well as the gut. Then there are these reactions that can occur. And there are a number of different foods that can do this. Amines can do it, sulfites, and just to name a few, which can also trigger IBS symptoms. So what can we tell patients with IBS? Well, we can give them a general dietary recommendation. We can tell them to maintain a brief diary of their dietary intakes and symptoms and see if we can find a correlation between the two. And oftentimes, just by doing that, patients will find it themselves. Talk to them about common triggers of foods. We all know that fatty or greasy foods have a variety of effects on the GI tract, which can exacerbate symptoms, particularly in IBS, alcohol, caffeine, and we'll talk more about FODMAPs in just a minute. We all know what FODMAPs stand for, so I won't belabor this point. And some of the examples of FODMAPs are included here, just to set a framework. But what we also know is that FODMAPs are not all created equal. And this was a study from a few years ago by Robin Spiller's group, where he looked using a functional MRI, the effects of various FODMAPs. And he particularly looked at glucose, fructose, combination of glucose and fructose, and fructans. And shown in the upper right is the hydrogen breath results. And you can see the significant difference in the red, which is fructose, and in the green, which is fructans, when the production of hydrogen, showing a very different time frame that occurs. Down below is the fMRI results. And if you focus in on the fructose, you can see that, which is a panel B, which you can see there's an increase of fluid within the small bowel that occurs. And compared to the far right, which is the fructans, which is there's not a lot of water in the bowel, but there's an increased amount of air within the colon. And this is a subsequent study that they did in the same paper using inulin, which is a type of fructan. And you can see on the right-hand side and the left side, increase of gas, particularly in the sigmoid colon and in the transverse colon. So the point here is that not all FODMAPs are created equal. We're going to talk more about this later when we go through the best of DDW as well, because there's some recent studies looking at the various components, which I think are very intriguing for the future of FODMAP diets in IBS. But let's go through what we know about it today. We know that for the low FODMAP diet, that the ACG guidelines recommend a limited trial of a low FODMAP diet because it's been shown to improve global symptoms. There's been it's a conditional recommendation. There's the very low quality of evidence, 7 randomized trials. 2 of these trials compared FODMAP to a usual diet, 1 to a placebo-controlled FODMAP diet, 1 to a high FODMAP, and 3 to other types of diets. What's important to note, when you compare a FODMAP diet to other diets like a modified NICE diet or a traditional IBS diet, there really was a non-significant trend towards favoring low FODMAP, but again, non-significant trend favoring it with it. All of these studies, though, only looked at the initial phase of the low FODMAP diet. As we know, there are 3 different phases. The first phase is when you take out the FODMAPs, and then the second and third phase is when you reintroduce the FODMAPs. These are only the very first phase, and they only are included studies up to 4 weeks in duration. So we don't have data for long-term therapy, good data for long-term therapy. Now, the pitfalls are important to remember. It's a complex diet. It's costly. Most effective when administered with a GI dietitian, but that's expensive and not always available. And it may have some possible negative impacts on quality of life. The unanswered questions include the effect on the microbiota, development of avoidant restrictive food intake disorder or ARFID, cibophobia, a fear of eating, and other nutritional deficiencies we don't know that much about. We don't have good information on that yet. But really, how do FODMAPs cause IBS symptoms? We know there are a couple of effects that we all think about. Shown on the left-hand side is the effect of small bowel. As it shows that when these sugars are not well absorbed, you get an increase in osmotic load. This causes increased fluid in the gut, increased transit, and can cause symptoms. On the right shows the effects on the colon. If you have increase in sugars within carbohydrates within the colon, you're going to get an increase in bacterial fermentation, which creates an increase in gas, which is what we all think. But it also, these bacteria also increase the amount of the production of short-chain fatty acids. This too can have effects on the gut. It can change the luminal pH, which again can change the environment for the microbiomes and changes the types of microbiome present, can affect permeability and visceral sensitivity. Shown on the bottom right, really an intriguing area that I want to explore just a little bit more further. And this is from Dr. Lacey's paper, where he said, well, there are other potential mechanisms that we haven't really been thinking that much about that may be important. An increase in mucosal release of serotonin and mast cell activations, among others. And in fact, there have been some recent studies that have shown that FODMAPs and foods in general can have a variety of different effects on mast cells and other immune activation effects within the GI tract. I'm just going to highlight 2 recent studies showing some of these local effects within the GI tract. And this is a first study was published from Detlef Schuppan's lab in Germany and in gastroenterology in 2019. And this is the figure that sort of summarizes it. So I'll just go through it briefly. On the left-hand side, they took a group of IBS patients. They were all IgE negative to food allergies, of course, and they underwent confocal endomicroscopy. And they looked within the small bowel after placing a food, 4 different types of foods in the small bowel, and they looked at the effects on the mucosal lining after this. And they divided them into confocal negative or confocal positive. And I'll tell you about that in just a minute. But confocal positivity, by their definition, included wheat in 60% of IBS patients, yeast 20%, milk 9%, soy 6%, and eggs 4%. This shows you a picture that comes from this journal article. Now, this is clearly probably one of their better pictures. We all know, for those of you who do confocal, know that you don't always see this type of clarity, but shown in the left upper in the A panel, you can see an increased number of intraepithelial lymphocytes that are seen. Shown in C and D is an increase in permeability that's occurring. These all occurred compared to baseline before putting the food in showed an increased number. And again, the percentages I showed you there um, with this procedure. There's also a paper that I'm not going to talk about at the best DDW. I just want to mention it for those interested that looked at the same technique, again, from another German group that showed that when they took a large group, over 300 patients, and underwent this confocal endoscopy, that they were able to give them a more tailored diet, and they showed reported improvement, not a controlled trial, but showed reported improvement in symptoms in the vast majority of those patients that had a positive study and removed that specific food. The other study that I want to talk about is also very interesting and received a fair amount of attention, published in Nature earlier this year, and it's entitled Local Immune Response to Food Antigens Drives Meal-Induced Abdominal Pain. This was predominantly, this is both an animal study and a human study, and I won't go, and it was quite elaborately done. I won't go through great detail given the time, but just to give you the highlights as shown in the figure, this figure, which appears in the paper. So basically, if you look at the middle column, in the middle area with break of oral tolerance, what they did in an animal model was gave the animal model an infection that caused a break in the lining of the colon, and then exposed the animal to a repetitive protein, in this case was ova, right after the infection, and that induced this tolerance to the food, and through a variety of studies to show that this was due to specific IgE antigen that stimulated mast cells that were sensitized. And not only the sensitized, they also had evidence of hypersensitivity associated with this as well. Then afterwards, they reintroduced that food to the animal and showed that they had an increased amount of sensitivity with it. So the important point was that this IgE food antibody was really detected only in the colonic tissue, that indicated this was really a local rather than systemic immune response against dietary antigen. So again, infection, break in the lining of the bowel, particularly the colon, re-exposing that same antigen that they were exposed to initially with the infection, later on caused the same type of symptoms that were very similar to IBS type symptoms. This appeared in the New England Journal last week that summarizes the same paper. And so the top panel shows just what we were talking about. The bottom panel is what I wanted to highlight here, that they're showing potential treatment options based on this hypothesis that may be important for patients with IBS. Now, some of these therapies are not available quite yet, but they're under clinical trials, not necessarily for IBS, but maybe used in the future for IBS. So intriguing, but H1 receptor antagonists are clearly available. Also from that same paper, there was the small human trial, which is intriguing as well. And again, here they injected gluten, wheat, soy, and cow milk into the colon, the sigmoid colon of 12 IBS patients, as well as 12 healthy volunteers. The arrows you see are pointing to the edema that is occurring. So up top is healthy volunteers. And if you look at the histamine one, you can see that there is a big circle around that area suggesting a reaction to it. And then you see that was pretty much the only one that was positive. And the healthy controls, there was one other person that had positive to soy. But if you look down below and just glancing at the various IBS patients, you can see there was an increased reaction occurred, and a number of the other foods that patients were exposed to. So I'm going to switch gears now, given the limited time, to talk really about the treatments of IBS and give you a high-level overview of the treatments for it. So let's first talk about IBS-C. The first-line therapy is psyllium or soluble fiber and osmotic laxatives, such as polyethylene glycol or magnesium-based therapies. This is based on our recommendations, and based on, not based on data, but based on the fact that these are readily available and relatively inexpensive and well-tolerated therapy. So we know the majority of people may not have adequate relief from these. The data on osmotic laxatives suggest that it does not help abdominal pain, but it will help bowel functions. Second-line therapy are really the secretagogues for IBS. And shown on the right-hand side is the mechanism of action of the 4 secretagogues that are currently FDA approved for IBS with constipation. As you can see, linaclotide and plecanatide stimulate the GCC receptor through the secondary messengers. Cyclic GMP open up the CFTR and cause chloride to be secreted. Lubiprostone opens CLC2, a chloride subchannel that increases chloride secretion. And tenapanor, which is FDA approved but not yet available on the market, but should be in the near future, blocks the absorption of sodium by the NH3 receptor. And of course, that could have different mechanisms, different uses within the body for other diseases, but for IBS, it's been shown to be effective. You can see the doses that are used, and remembering that lubiprostone for IBS is only approved for women with IBS. For chronic constipation, at the higher doses approved for both men. There was a recent network meta-analysis that tried to compare the efficacy of these drugs head-to-head, although this was not a head-to-head study, but they tried to compare them head-to-head based on the data that was available. Now, and as you can see, in this network meta-analysis, that all of these therapies were shown to be effective compared to the placebo, all tending towards the left. And in general, they were all relatively similar in efficacy. Linaclotide maybe a little bit more, but not that significantly different between them. So in general, the therapies, at least based on the FDA endpoint, are known to be relatively similar with it. I do want to emphasize one other therapy that's relatively new to the market, reintroduced newly to the market, that some people may not be familiar with. This is Tegaserod, which is a 5-HT4 partial agonist. And it is recently reapproved, as I stated, at a dose of 6 milligrams twice daily for women under the age of 65. There is no new data with Tegaserod. Rather, the data shown on the right-hand slide is old data this is a study from Bill Che with IBS-C and IBS mixed, showing the overall improvement with Tegaserod, including women over the age of 65. When the FDA looked at just women under the age of 65, the data was relatively similar. Side effects in patients with a history of MI, stroke, TIAs, or angina, or ischemic colitis, end-stage renal disease, or hepatic impairment with it. And again, just to emphasize, it was taken off the market due to concerns of cardiovascular side effects. There was a mismatch between when they pooled all the Tegaserod trials that were done up to that date versus placebo. Subsequent re-review of the data suggested that almost all events occurred in people that were over the age of 65 or in men that were younger that had other risk factors. So the FDA considers it to be safe if you don't have a risk factor for cardiovascular events. Switching gears, let's talk about IBS with diarrhea. First-line therapy is going to be loperamide, followed by bile acid sequestrations. Again, not based on clinical trial data, but based on the fact that these are widely available, relatively inexpensive, and relatively safe. These are recommended first-line treatment options. Second-line treatment options would be rifaximin. And as we know, it's approved for retreatment ×2, as well as eloxatiline. That's not contraindicated in people with sphincter or Bode dysfunction, a history of pancreatitis, and those who drink more than 3 alcoholic drinks per day or have had a cholecystectomy. I put this down as third-line agent treatment, which would be a losatron, just given its restrictions on it, but knowing that the data suggests it's quite effective. It's restricted due to the history of ischemic colitis in about 1 in 1,000 patients and severe constipation at high doses. Looking at another network meta-analysis by Alex Ford's group, you can see here that all drugs were found to be superior to placebo, but losatron and ramosatron, which is not available in the United States, ramosatron is, appeared to be the most effective for this. And it's interesting to note that rifaximin does cross the 1 so suggesting that it may not be quite as effective as some of the other therapies, at least based on the FDA endpoint. Just to highlight the retreatment data with rifaximin, this was a complicated study, but when patients were given first and second retreatment with rifaximin, there was a small but significant difference, suggesting again that you can retreat patients who respond to rifaximin with it. I do want to just briefly talk about some of the how to treat patients who have pain predominant symptoms. In addition to improving their bowel functions with some of the treatments we've talked about earlier, you may want to consider adding some drugs or some treatments that may improve pain. And here we have antispasmodics. The two available in the United States are hyoscyamine and dicyclomine. The doses are shown here. It's interesting to note that the ACG recommends against the use of antispasmodics for global IBS symptoms, but specifically, at least in my practice, in my experience, that it may help abdominal pain, particularly we used on an intermittent basis with it. But again, limited data, old studies, really poor quality. Be cautious of their use, particularly in the elderly, due to the anticholinergic effects. It's worth also mentioning peppermint oil. The ACG guidelines suggest the use of peppermint oil to provide relief of IBS with conditional recommendation with it. Most of these studies with peppermint oil have used a dose between 180 and 200 milligrams up to 4 times a day. And all of these, of course, are enteric coated. I do want to just point to on the graph on the right, this is the most recent study done with peppermint oil. Interesting study because it had a small bowel release peppermint oil, which is sort of the typical peppermint oil that's sold over on the market these days, versus an ileocolonic release of it. And this was a fairly large trial, over 60 patients per group. What's notable is that there was no significant difference between the groups, statistical significance, although the small bowel release, as you can see, had a numerical difference over placebo, but not different, significantly different over the ileocolonic release. So really, more larger trials with peppermint oil really should be done with it. Other drugs you might use for for pain predominant symptoms are tricyclic antidepressants, and the meta-analyses suggest a very good number needed to treat of 4. The first line treatment would be a tricyclic antidepressant such as amitriptyline or tizipramine, and then a second or third line would be SSRI, SNRIs, or tetracyclic antidepressants. And I've listed some of the indications that you may want to use these various antidepressants there. And this all comes from Doug Drossman's review in gastroenterology, which is excellent if you haven't had a chance to read it. And as Doug sort of indicates in this review, it's important to talk to patients about potential side effects. For tricyclics, we'll start low on the dose, particularly in those in elderly or somatization disorder. Try to get to a dose of 50 milligrams. Consider switching to an SSRI or other types of antidepressants if you get side effects. And again, particularly with the TCAs, for patients, for example, that have difficulty in sleeping, you may want to use one of the TCAs, such as amitriptyline, that has greater effects on sleep. That may be helpful for you. We get a lot of questions about probiotics. It's not listed in those various algorithms I gave you, but those algorithms are not exhaustive by any means. And I know we may all use different therapies. I just want to highlight a couple of areas. One is this probiotics. This is the ACG guidelines, and the AGA guidelines are very similar, which recommend against the use of probiotics for the global treatment of IBS. Very low evidence. And the reason for this is really small studies, multiple types and strains of probiotics, inconsistent benefits on individual symptoms, and lack of rigorous trials. So really not enough data to make strong recommendations. Doesn't mean you shouldn't use probiotics. I use them in my practice. And I certainly have specific ones that I recommend based on my experience, but just understand that the guidelines suggest that there really isn't enough data to use it. I'm not going to talk much about psychological therapies. I just want to highlight the ones that have been shown to be effective and the ones that most commonly used. And these are shown in the bold, which is most commonly studied and probably used in our experience is CBT. It is interesting to note that now this is being done remotely via Zoom and other avenues, which is really helpful for patients, and the data suggests that it is as effective as in-person CBT. And the same thing goes with hypnotherapy. This is being done virtually as well, and seems to be effective as well. So this is really, hopefully there'll be more options for patients to do this in the future, because as you can see, the data suggests that it can be quite effective for it. And lastly, I just want to talk very briefly about FMT in IBS, because this comes up a lot. This is a review from just a few years ago that showed that in general, as you can see, there's a wide variety of effects, and showing the overall effect. Looking on the right-hand side, you can see it's flat on one, suggesting that overall there's no effect. But clearly there's some differences between these trials. Some show pretty significant, and some show even some negative effects that occur. There's a lot of differences between the studies: the route of administration, the dosing, fresh, frozen, number of donors, and really the subtypes of IBS. So really, these you can see the small numbers of patients with it. I want to highlight one study, though, that's the most recent of the FMTs, and the one that shows the most dramatic effects as well. So it's worth just looking into this in more detail. What's notable about this is a single donor for all of the patients in the study. They called it a super donor, a very healthy male that had been only exposed to antibiotics 3 times in his lifetime, taking some vitamins like vitamin D, but no other medications, no strong family history, etc. Exercises regularly. So they considered this a super donor. It was a frozen FMT placed in the distal duodenum via an upper endoscopy. The dosing was 30 or 60 grams. So this is a little bit higher than what's used in some of the other studies, and all subtypes of IBS. And just shown on the right-hand side is some of the dramatic effects, maybe too good to be true. I think that would mean to be proven, but to see almost 90% of people at 3 months receiving the high dose had a positive response based on the IBS-SS with a drop of 50. I'll just note that the placebo response is very low here. So even some of the studies that we and others have done with IBS-SS would see a higher placebo response rate. But I think this is really intriguing data, and we have not heard the last of FMT and IBS. So in conclusion, it's really the cornerstone of treatment is a clinician-patient relationship, and those techniques I explained, I think, are helpful. Most of them are intuitive, but are helpful to improve not only the outcome for patients, but also your satisfaction in taking care of these sometimes difficult patients. Diet, exercise, sleep, and stress are the cornerstone for IBS-C, D, and pain. I've listed here some of the treatment options, and it's important to note that there are 8 FDA-approved treatments for IBS. And every time I quiz a fellow, they always think that there's 1 or 2 that are available. So it's important to remember there are a number of options. Psychological treatments, we didn't really go through much of CAM except for probiotics. Those remain insufficiently studied to make routine recommendations. And then remember that this is a stepwise approach. For the vast majority of people, we may not need to go beyond diet, lifestyle, and advice and reassurance, pharmacological therapy, and then even some of the psychological or centrally acting therapy for the more moderate and severe patients. So with that, I'd like to thank you for your attention. And again, thank you kindly for the invitation to present to you today.
Okay, that was a great talk by Dr. Lembo. I got to say, we apologize for the audio quality. We got to check the slides before, but not the audio. Maybe his office is a little too close to Logan or something. Planes flying overhead. But he will be available for Q&A in the afternoon after he discusses IBS abstracts from DDW. We're going to break now. Again, this room will turn into a product seminar lunch. I think Sammy Saab is speaking. There's lunch. Go visit the exhibit hall, and we'll meet back here at 1:15 for the second half.
Thanks, Tony.